Okay, I think we'll get started. Welcome to the Johns Hopkins University Virtual GIS Week. You're currently in the session on COVID-19, as I said. We're so glad that you're here and able to join us. We have an exciting group of experts on our panel today. My name is Michael Desjardins. I'm a postdoctoral fellow in epidemiology, and I'm also part of the Spatial Science for Public Health Center here at Hopkins. First, I'd like to introduce our co-sponsors. GIS Week is sponsored by the Johns Hopkins Center for a Livable Future, an academic research center focused on the intersection of public health, the environment, and the food system, and also sponsored by the Johns Hopkins Spatial Science for Public Health Center, which is an academic research center focused on the development and application of spatial analytics, GIS, and spatial statistics for public health research. Before I introduce each panelist, I'd like to go over a few housekeeping notes. We will be recording this webinar and we'll make it available after our sessions are complete on our landing page. So stick around for those links at the end of this panel. Feel free to post questions for the speakers in the Q&A box. We will have time for one question for each speaker after their talk. And then at the end of the three speakers, we will have an open Q&A. For about 10 minutes or so. So without further ado, I'm honored and happy to introduce our three panelists today. First, we have Ensheng, who is a PhD candidate and Lewis M. Brown Engineering Fellow of the Department of Civil and Systems Engineering and the Center for System Science and Engineering at Johns Hopkins University. He is also a member of the Infectious Disease Dynamics Group at the Bloomberg School of Public Health here at Hopkins. He is interested in interdisciplinary research on network science, mobility modeling, spatial analytics, geovisualization, and infectious diseases. His recent work includes forecasting the risk of measles in the US and the Pacific Island countries and territories. He's also interested in predicting dengue outbreaks in Sri Lanka. And he's building and maintaining the Hopkins coronavirus dashboard, which he will present on today. He's also interested in modeling the global coronavirus pandemic as a result of that. Next, we have Alexander Hohl, who is an assistant professor in the Department of Geography at the University of Utah. He has received his bachelor's in geography from the University of Zurich, master's and PhD degrees in geographic information science from the University of North Carolina at Charlotte. His research focuses on computational aspects of spatial analysis with application to health geography. Alexander has authored and reviewed multiple articles in peer-reviewed scientific journals, including the International Journal of Geographic Information Science, Spatial and Spatial Temporal Epidemiology, and Applied Geography. Alex Hohl currently serves as the chair of the Cyber Infrastructure Specialty Group for the American Association of Geographers. And finally, we have Eric Delmelle, who is an associate professor in the Department of Geography and Earth Sciences at the University of North Carolina at Charlotte. He has 10 years of experience in the development of novel geospatial methods and interactive visualization techniques to the field of public health. His research attempts to answer fundamental epidemiological questions where spatial and spatial temporal methodologies are critical. Eric has developed new, robust geocomputational approaches to deepen the understanding of the dynamics of infectious and non-infectious diseases, and his research has been funded by the March of Dimes, the Centers for Disease Control and Prevention, and the Water Resources Research Institute. So that's a little background about our three panelists. And now, without further ado, I'd like to ask Ensheng to share his screen and start his presentation.
Hey, good morning, everyone. This is Ensheng. I'm the second-year PhD student at Johns Hopkins University. Today, I'd love to share some interesting stories about our world-famous coronavirus tracking dashboard, like how we got started and how we collect the data, share the data, some challenges we have been facing, and how we use GIS to deal with them. So you may have been very familiar with this dashboard. If you don't, you can go ahead and type in this URL in your browser, and you can see our dashboard. The main part of the dashboard is a map, and each red dot represents the number of cases for that location. For the US, we are tracking the cases at the county level. For some other countries like Canada, Australia, China, the UK, Spain, we are tracking at the province or the state level. And for the rest of the world, we are tracking at the country level. And on the right and left-hand side, you can see a bunch of the list widgets and some numbers, and those are the cases for different countries. We have the total cases, the death, the recovered. We also include some US specific information like the testing rate. At the lower right corner, you can see that in the yellow box, a bunch of the epidemiology curves. So we have the daily cases, daily death. Those are in the bar charts, and cumulative cases and cumulative death. Those are the line chart. And we also have a log graph. So down below this map, you will see we have a series of tabs, and those are very easy to be ignored by the general users. But those tabs include the maps, which is very helpful. The first one is the active cases map. Active cases means the total number of the cases minus the death minus recovered for each location. And for the incidence rate, the second one, also the yellow dot map, incidence rate means the number of the cases over 100,000 residents in that area. And third map is case fatality ratio. It means the number of the cases over the number of the, the number of death over the number of the cases for that region. And we also have the US specific testing rate map that is at the state level. And just in this morning, Time Magazine just announced our dashboard is one of the best innovations of 2020, and I'm so proud of that. So cooperated with Johns Hopkins Coronavirus Resource Center and the Civic Impact, we also have a US specific map, and this one is focused on each county. And one of the most important feature, I think, is when you click on the county, you will see a pop-up window, and in this pop-up window, there will be an infographic. Click on that infographic, you can see the details for that county. The information include the public health information like the number of the ICU beds and number of the physicians in that county, and also the demographic background for that county. I believe this one is very helpful for the health experts. If you want to know more information on those two dashboards and some other trends and plus, you're welcome to visit Johns Hopkins Coronavirus Center. So how we got started about this project? Well, that can go back to January 21st. That's a Monday, I remember, and my advisor, Dr. Lauren Garner, and we had a meeting that morning, and she bought me a cup of coffee. And she knew I was tracking the coronavirus in China, and she suggested me, why don't you create a dashboard? And I was so happy because that was one of my goals for that meeting, to create a dashboard for the coronavirus. So after the meeting, back to the office, I just used 8 to 9 hours and created the first version of the dashboard. And you can see this is the first version of the dashboard. And the next day, January 22nd, Dr. Garner tweeted this one to the whole world. And then Johns Hopkins University and the Lancet Infectious Disease, they are also retweeted or promoted our dashboard to the academia. But it's also got the world fame. For example, this is a usage plot of the dashboard for the first couple of months, and the highest daily usage you can see can go up to 4.5 billion requests per day. So if you compare with the population of the world, I can say on that day about two-thirds of the population in the world, they had at least one click on our dashboard on average. So this is the latest statistics. So by far, for the feature layers and the dashboard we have, we already got about 200 billion requests in total. And another way to see the usage is break it down by country or region. So here each color represents a different country or region. And this usage graph goes up and down, and that matches with the surge of the coronavirus in the world. For example, the first peak of the usage, you can see we have Italian cases, and the second and third peak associated with the coronavirus surge in Europe and Middle East and the US. So who are our users? This one is one of our users, the current Vice President of the United States. When he was visiting the Department of Health and Human Services, you can see the background is our dashboard. And this is in German government. This is Italian government when they are making the important social policy, and they are referring to our dashboard as the #1 source. And the data is also being used by United Nations. And I'm so happy that our data is also being used in academia. Like the first one is from the University of Washington, IHME, and they are making the projection for the coronavirus, and the results was reported to the White House. And on the right hand, you can see our data is used in most models to project the coronavirus, and this one is conducted by CDC. Some other examples of the usage, like New York Times is using our work data for the coronavirus map. And this is a typical CNN map. As you can see, the right upper part will be the pandemic information, the lower part will be the stock market, and sometimes if the cases are going up on the top, the graph will going down on the bottom part. We also got a lot of interviews and news report by a lot of medias like the NPR and the Science magazine and Nature Index. And one comment from the Wall Street Journal, they say our dashboard is the historical first. It is because we are the first dashboard in human history to track the pandemic in real time, and the audience is everyone in the world is our audience. Because of our dashboard, many other organizations, they started to use and adopted Azure dashboard to create their dashboard or visualization. For example, this is from WHO, and this is from Japan. And under Japan's dashboard, they clearly stated that they are using Johns Hopkins University's dashboard as the inspiration for their dashboard. And this one is from Hong Kong, Macau, China CDC, Italy, Singapore, Thailand, Israel. You can see Thailand and the Israel dashboards, they use our feature layer as their base map, and also they switch the language from English to their local language. And this one from the Philippines, South Korea. So because of the usage of the dashboard, the vice president of Johns Hopkins University did a survey in Twitter. This is just for fun, and people think our university is the #1 or the most impactful U.S. institute in dealing with the coronavirus. So a lot of users here, they are from the GS or from the public health background, and I believe you know the importance of the data, garbage in, garbage out. So from the very early days, we are tracking the data in this Google Sheet. We can see on which day and who collected and which areas information and what's the data sources for that. This is all manual stuff. However, as you all know, we are tracking all 3,000 plus counties in the US and more than 200 countries or regions in the world. It's really impossible to track everything by hand. So since the early February, we are getting started to adopt some automation process, which includes 3 steps: the data collection, data curation and sharing, and visualization. In the first stage, data collection, we collect the data from the most trustful resources, like the local government or the Department of Health and the major media. We collected all those information and make them in the standard formats. Something like we translate the language and also clear their definitions of certain terms, like the cases. If the cases include both the confirmed cases or also include the probable cases, we need to figure that out. And after that, we made a clear table and share the data in the GitHub repo. So initially, we shared the data through the Google Sheet, but we found the 101st user, they cannot download the raw data because of the limitation of the Google Sheet. So we changed or transferred our the raw data to the to the GitHub repo. And in the GitHub, we share two types of data. One is data report. This is the raw data for the dashboard. We collect the data every day, and we post all the information to the GitHub in the daily report folder. And we have another type of data. We call that time series table. The purpose for this one is to create a collective table, aggregated all the information, including the country and time in one giant table. So the researchers or the general users, they download this CSV table, they can easily plot the time series for any locations in Excel or in another applications. And we also relying on ArcGIS hosted feature layer to share the ArcGIS version of the dashboard of the ArcGIS version of the data to all the other users, for example, the government or other agencies. When we collect all the data, there is another important steps we need to go through. That is anomaly detection. Why we do that? For example, some country reported 100 cases normally, but some other day they just report over 1,000 cases, daily cases. This may happen, but from common common perspective, we think that one might be something wrong. So we need to figure out if it's the error from the data source or the error from our data pipeline. So at that time, the system will send us alerts automatically, and a member of our dashboard team will go into the system and see what's going on. And when they think it's okay, and we will give a green light and pass on the data to the next stage, visualization. So in the visualization, we have two versions. First one is the desktop version. That's the one I shared you in the beginning. The second one is the mobile version. You can switch two different versions by tab or click on the button on the upper right corner of the dashboard. So by far, we already got more than 24,000 stars in the GitHub, and we were also ranked #1 in the GitHub training list without a single line of code. This is not common. And this is our effort since the early February. As you can see, almost every day we are committing some data change to this data repo, and we will keep working on that until the end of the pandemic. This is an overview of the GitHub. If you are interested in using our data for scientific research, you can download the data report and time series table, and we have the full list of the data sources we are using. And another important thing is the data modification records. Some local Department of Health, they may back distribute their information. If we catch up the change, we will also make the change in our time series table, and we record each change in the GitHub. And recently we changed the terms of use. So right now, almost every organizations, no matter you are commercial or non-commercial organizations, you're welcome to use our data. And one example is Google Map. They are using our data to show the COVID-19 tendency in your location. Here is some GIS challenges we have been facing in creating this dashboard. So compare with the first version of the dashboard. The first version of the dashboard is on the left-hand side, and the right-hand side is the latest design. And you can see our default map extent changed from East Asia to the whole world, and also we added many epidemiology related information like the curves. We have the daily cases and the cumulative cases curve too. We also have some GIS challenges like what type of the data shall we present to the users, like how we visualize them. For example, we can visualize the number of the cases in the polygon or in the chloroplast map, or we can just make the map like the dot map. So to represent the number of the cases. Which one do you prefer? So we were discussing this problem a lot. Another thing is, where should we place the dot? One example is the Diamond Princess, when the U.S. government decided to evacuate about 50 patients from the Diamond Princess cruise ship, and we were wondering where should we locate those patients. And some of them, they were scattered into different U.S. military bases or in local hospitals, and they are constantly in the moving. So it's really hard to track their location in real time. And we also concerned about the privacy. In the end, we decided to aggregate all the patients in one dot and place that dot in the geologic center of the U.S. continent. That is somewhere in Kansas. However, the next day, Kansas residents, they don't like it because they believe if there is a dot, there will be a coronavirus patients, and they don't think so. So they reported to the university and even to the White House, and complaining that we shouldn't place the dot on top of their apartment. So we moved the dot back to Japan as a temporary solution. And then we also designed a way to show the data in the dashboard list, but not show the dot in the map. And we call that one as a null island. Another way to keep our data reliable is to compare with other data sources like WHO. And from the two bar charts, you can see most of the days our data align with WHO, and even we reported earlier than WHO. And if we have some exceptions like those bars, and those bars spikes represent the data from GHU, that is because China, they changed the standard of the cases. So we catch up that change earlier than WHO and reported more cases for those days. And another comparison is on the first when each country reported their first case. And you can see on the upper part is when Johns Hopkins reported the first case for each country or region, and lower part is WHO. And the blue, if the country in blue, which means we reported earlier, and it being red means we report a little late. I have to admit, because in the early days, I was the only one person maintaining the whole database manually. So I missed a couple of regions because I was kind of exhausted in the early days. And we published this paper to Lancet Infectious Disease, and we already got over 2,000 citations. That's very impressive. We also compare our data with other US data sources like the USA Facts, New York Times, and the COVID tracking projects. For the cumulative cases, we line with each other perfectly, but for the cumulative death, we have some spikes. That may be because we are reporting the probable death, and some other data sources, they don't. And another example is from France, why we have so many spikes compared with the WHO data. One reason is we are reporting the probable cases for France, and another reason is we are reporting the French overseas territories cases into France. Some other interesting example, including the Cyprus. If you are familiar with the global geopolitics, you will know there are different entities in that island, and we need to make sure if the data is from southern part or from the northern part or from both sides. We have some issues with Iran. Can the users from there use our dashboard by the US regulations, and how we report the data from Crimea, show that the cases belongs to Ukraine or belongs to Russia. We have so many distributed territory issues, and to solve that problem, we follow the naming conventions and the rules from the U.S. Department of State. Since the late January, we are collecting data of the coronavirus, and we have no reference, no previous experience, and there aren't too many previous studies on tracking the pandemic in real time. So we have to start everything from beginning and solve all the problems by ourselves. And some other issues we were dealing with, like the ambiguity of the parameter definitions. For example, if I say Baltimore reported 10 cases on April 1st. Does this date, April 1st, means the date the patients got the virus, the on-site date, or the local health department reported the case, or that's the date JHU collected the case? So we have some naming issues on that. And also we are having some discrepancies in reporting across different data sources. For example, one county may report the case way far more than the state report the case for that county. So how we handle that? So for all those problems, we put our thoughts in a newly published letter that is also in Lancet Infectious Disease. And if you're interested in, you're welcome to take a look. And in the end, I'd love to show my appreciation to all our lovely team members. And because of their efforts that make the dashboard up to date and keep it running every day and keep saving the life. And I'm so proud that my advisor, Dr. Garner, also on the list of Time 100 most influential people in 2020. And for the whole team, we got the award, Making a Difference award from ASRI this summer. I also like to thank our sponsors. Because of their sponsorship, that make our Johns Hopkins University not only famous for the medical school, but also famous for the coronavirus map. Last, I would love to invite you to visit our website and join us if you are interested in. We are recruiting some PhD students and postdocs. If you are interested in, please check our website. Thank you. Back to you, Michael.
Thank you, Ensheng, very much for that really insightful talk about the dashboard. I'm sure many of us were wondering about the back end and what went into actually making the dashboard early on. We do have a bunch of questions, but I'll save those for the discussion part of this at the end of our three panelists. But just a quick question before we transition to Alex. How often is the dashboard updated? Once per day, twice per day?
Oh, that's a very good question. So we have different platforms. For the GitHub, we have an internal update that is 20 minutes, every 20 minutes, which means every 20 minutes we'll go through all the scripters for all the countries in the world. We will grab the data. For the data report, we will present the data every day. But for the dashboard, we will update the data once per hour.
Awesome, thank you.
Yeah, thank you.
Okay, Alex, if you want to share your screen now.
Sure, let me go ahead. Can everybody see that?
Yes.
All right, thank you. Yeah, so my name is Alexander Hohl. I'm from the University of Utah, and the title of my talk is Daily Surveillance of COVID-19 in the United States. Typically, I start my presentation with some statistics on the coronavirus in the United States, but typically those numbers, as you know, are already outdated the next day. And after Ensheng Dong's presentation, everybody knows where to look up the newest numbers. So I will skip ahead and introduce what we're doing. So it is important to monitor the disease during a pandemic like that. So surveillance deals with finding spatial and spatiotemporal patterns. And the reason for doing so is we want to be able to inform health authorities to prioritize locations for targeted interventions, rapid testing, and resource allocation. So I'm in Utah, and hospitals are at capacity right now. And the capacity of, let's say, ICU units is not limited by the rooms or by the beds or even by the ventilators. even not by the doctors. Right now, I'm hearing the healthcare providers are limited in the number of nurses. So if you're a nurse in Utah, you can make $160 per hour right now. So think about how much money you can make if you have 3 shifts of 12 hours per week and you work for a full month. That's a lot of money. So you can see that, you know, resource allocation is very important. We're trying to get the you know, enough staff to you know, deal with this crisis. So for that, you can see that, for example, here on the right side is a map of you know, the case incidents at the county level across the United States, and you can see that we have these at this point in time, you know, higher incidence in the southeastern United States and lower incidence in these areas where you know, the counties are not so red. And you know, what you see here is like a gradual, you know, spatial gradient, right, from high incidence to low incidence. However, wouldn't it be nice to be able to, you know, draw a straight boundary, you know, that you know, so we have this binary situation where either you're in a high risk area or you're not, right? And this is what we're doing by applying the space-time scan statistic, which was invented by Martin Koldorf and refined in many follow-up publications. The space-time scan statistic is a clustering method that identifies disease clusters, and we have the following outputs. We know the geographic location of these clusters. We know their size. We know the duration, okay? So there's a temporal component. We know their strength in terms of risk and their statistical significance. So we know whether they occurred by chance or not. And you can see here, it works by this space-time cube framework where you have the latitude and longitude as X and Y axis, and time progresses in the vertical axis. So early cases are drawn as dots at the bottom of this graph, and the later cases at the top. So the space-time scan statistic comes in its discrete prospective Poisson form, which we are using. And here the assumption is that cases follow a Poisson distribution according to an area's population. Okay, so that is the Poisson model, and we test the null hypothesis whether the model reflects an inhomogeneous Poisson process with intensity mu at you know, which basically saying that the risk is proportional to the at-risk population. Okay, so basically that is what you would expect, right? The expected situation. And the alternative hypothesis would be that more observed cases than expected from the null model in a given scanning window. Okay, so we have an elevated risk cluster, so to speak, right? So we evaluate these hypotheses using a maximum likelihood ratio test. And since we are using the prospective version of this space-time scan statistic, we disregard historical clusters and identify prospective clusters that are active today on the day of analysis. So we are not interested in clusters that you know, occurred, let's say, in March or April, right? We are interested in clusters that are active right now in November 2020. So for those of you who have no experience with the spatial or space-time scan statistic, let me explain it in simple terms. So I'm using the spatial scan statistic for simplicity, but the same concepts apply in space and time. And as you can see, I have my country here, with which is divided into some regions. We have, for each region, we have the centroid, and for each centroid, we know the number of cases and the population that are within this region. From that, we also know the entire country's population, which in this mock-up example is 100, and the number of cases, which is 10. Then we draw our first scanning window, okay? So in this case, a circle. This is a candidate cluster, and we want to evaluate whether this cluster is just a candidate or whether it is a significant cluster of elevated risk. And you can see that the circle is centered on this centroid here, but it also encompasses this neighboring centroid. So it means that we are looking at these two regions here. And in these two regions, we find that the observed number of cases is 4. And we also find that the population is 25, which means under the null hypothesis, the expected number of cases would be 2.5, right? So you can already see that, okay, we are observe more cases than expected. From these two numbers, we can also calculate the number of cases that is observed outside the scanning window. So 10 minus 4 equals 6. And also the number of expected cases outside the window. So 10 minus 2.5 is 7.5. Simple, right? And then we plug these numbers into this likelihood ratio equation, where you basically can see that there's these ratios of observed cases inside divided by expected inside, observed outside by expected outside. And in this mock-up example, the number that we get is 1.7. So this circle has a likelihood ratio of 1.7. And so it's like a quantification of the strength of this candidate cluster. And of course, we test multiple different clusters. So, you know, and I made up some data here, and you can see that the likelihood ratio for increasing radii is decreasing, right? So in this example, if we had these 3 candidates, we would pick this one in the middle, right, because it maximizes the likelihood ratio. Of course, we also, you know, test every possible circle. So we move this bullseye from centroid to centroid. And so here you can see how we establish the data set of likelihood ratio numbers for our study area. Now, we do statistical significance testing. We want to know whether these clusters, candidate clusters, occurred by chance or not. And we use a Monte Carlo simulation for statistical significant testing, where we simulate 99 or 999 you know, data sets, and we compare that to the observed set, so we can compute p-values to see whether the cluster is significant or not. So this whole procedure results in a selection of significant clusters of elevated disease risk. We know cluster location, size, and duration. We also know the relative risk inside the cluster, and also the relative risk of the locations that belong to that cluster. These are 2 different things. And then we have expected counts for clusters and locations belonging to clusters, and also the log likelihood ratio. So we use data from the Center for Systems Science Engineering, CSSE, at Johns Hopkins University. I'm very glad to follow up on Ensheng's presentation, because now it's very clear where the data is from. And for the population, we use 2018 ACS 5-year estimates. And to compute this space-time scan statistic, we use the satscan.org application, which is conveniently free to download. So we use that. And so in the first run, we computed the clusters for March 9th, 2020. And you can see that we essentially get 2 different regions here in the Pacific Northwest and here in the New York area, where Westchester County had this very early outbreak. And you can also see the you know, tabular view with some of these outputs that we get from the clustering process. Here, for example, we see the duration of the cluster. So the cluster number 1 in the Pacific Northwest started on February 29th. It is significant, and you can see the number of observed and expected cases, as well as the relative risk. So then we were asked to perform the same analysis again for March 27th, where we can see that this big cluster in the Pacific Northwest has vanished and has now reduced to just 3 counties around King County in Washington. You also see that there appears to be like a spillover situation where in the New York area where the disease has spread, may have spread to its hinterland, so more rural counties in Pennsylvania, New Jersey, and so forth. You also see some isolated one county clusters or outbreaks. And one of these here in Utah is Summit County, which is a resort destination. So people go skiing in Summit County, Park City, Utah, and they go there for a week and they leave they bring the coronavirus to this county. So that's what we observed for March 27th. And then again, a month later, we see that these single isolated outbreaks seem to have consolidated into bigger clusters of elevated disease risk. Interestingly, Summit County in Utah has disappeared from significantly elevated risk. So that's great, right? We have these snapshots in time, and for each of these snapshots, we have all of these metrics. So we thought, okay, why don't we do that for every day? And yeah, that's what we did. That's how we created the COVID-19scan.net application, where we perform daily surveillance of the virus using the space-time scan statistic I explained. And since we do that every day, we have this interactive web application that draws the circles. As you hover over the circles, you can read these characteristics, and there's like a time slider where you can see the development of clusters over time. But we can also illustrate the cluster characteristics in these time series. And for example, the population inside cluster, starting from the beginning, expectedly, right, shot up and had its peak here, followed by a period of chaos and fluctuation, and then decline and stability. And so this is the story across many of these cluster characteristics that we observed. Also, we have the observed number of clusters, which goes up, and the duration. And interesting, the log of the likelihood ratio that I explained earlier also follows like a increase, chaos, decrease, stability type of trajectory. So yeah, so here I invite you to go take a look at the COVID-19scan.net app, where you can see the clusters for the United States. I would like to spend some time summarizing. So here in this effort, we identified COVID-19 clusters, their geographic location, duration, strength, and statistical significance. We did so in the United States, in the contiguous United States at the county level every day. And by doing so, we can track cluster characteristics and hope to inform or guide health authorities with their decisions. I also want to mention, some open challenges or some ongoing challenges. And one of the challenges that we thought is most important is that case counts may be confounded by testing effort. So you know that our clusters are based on the Johns Hopkins data, right, of case counts. However, there's been this discussion where not every state has the same testing effort. So the number of administered tests differs from region to region. And so, of course, if you test more, you might observe more cases. So that the fear here was that the clusters that we find, are they clusters of COVID-19 cases, or are they clusters of COVID-19 tests, right? So we need to adjust the number of cases by the number of tests. And however, that data is not available for every county in the United States, and we do our analysis at the county level. It is accessible for some states at the county level, including New York, California, and so forth. So we, in this follow-up effort, created a machine learning model to predict the number of tests from those states that report the number at the county level to those that don't. And you can see that our predictions nicely capture this weekly pattern of tests where you have less tests in the weekend. Also, the observed testing rate versus the predicted testing rate shows a nice correlation here. And so this is a work in progress, and you can see our current predictions. You can get the data free for you to use in this GitHub repository, which later on I will share in the chat of this conversation. So yeah, that's what we're currently working on. I hope you enjoyed the presentation. I hope it was informative. I'd like to acknowledge my collaborators, Lan Yu and Michael Desjardins, Eric Delmelle, and Simon Brewer. Thank you very much.
Thank you, Alex, very much for that talk. We do have some questions for you. Just a quick one before we move on to Eric, and then we'll ask the rest during the discussion. Could we use your application for other countries if we have the necessary data? And have you tried your application with other country data?
No, we have not. It's a good question. I think the StatScan is a or the spatial scan statistic is applicable to any geographic region, and so yeah, if we had the data, we could certainly try to have to do the same cluster detection effort for other countries. Yes. However, right now we feel like we have the best local knowledge of the United States. So I'm not sure whether I'd feel comfortable doing that for other countries that I don't know as much. But yes, it's certainly from a technical perspective, from a methodological perspective, absolutely feasible. Yes, thank you.
Yeah, especially because StatScan is free. Anyone could go on and learn. There's tutorials and whatnot. So yeah, thank you for that. Now we'll go to Eric before we have our open Q&A at the end. So Eric, if you could share your screen.
Okay, Mike, can you see my screen?
Yeah, very nice. Thank you.
Okay. All right. Good morning or good afternoon, everyone, wherever you are. So I'm really happy here to share some recent work that we have done with co-authors Alexander Hohl, that you just heard, Michael, who has put together with his colleague this GIS Day event, and Yulan, who is a PhD student at the University of North Carolina at Charlotte. And for conflict of interest, Alex and Michael used to be former student of mine. So we work together. Alex has shown some of the work that we have done. But the focus of this talk today is trying to push the boundary a little bit further in terms of visualization of COVID-19 and going beyond dashboards. So I am going to, of course, discuss a little bit about the benefits of dashboard that kind of ties into the first presentation. And then I will share some of the visualizations that we have worked on, some that are novel, some are maybe a little bit less novel, but they are worthwhile pursuing. And so hopefully this talk will be refreshing for many of you. So I want to give a bit of background on dashboard and not that we don't know what it is, but we have to come to realize that we live in a very data-driven environment. Of course, we think about our cell phones and data that is collected from there. There are challenges to manipulate and analyze data from different sources. The first presenter was talking about that as well. And how can we show trends and how can we show variation? For instance, the Johns Hopkins dashboard does a very good job at showing trends. Does it do a good job at showing variation over time, or over the last 2 weeks? A question to be asked. How can data be analyzed accurately to derive actionable intelligence? So once we have all this data put together into a common platform, how can we use it to derive decisions? So how do public health decision makers use that information? All this relevant information on a single screen that can facilitate, sort of a quick understanding of this data is made possible through dashboards. So COVID-19 dashboards have been very useful for not only the timely understanding of the disease dynamics and the source, the epidemiology, of course, the circulation of the virus, and also inform public health decision makers on various measures to limit the spread of the virus, such as confinement, stay-home orders, or social distancing where needed. So what kind of measures are necessary? What kind of essential or non-essential stores are allowed to be open and so on to limit the spread. So there was this very good article by Bulas, who is the editor of Health Geographics, that I encourage you to check out earlier this year. We also have noticed, and the first presenter mentioned that COVID-19 dashboard have just exploded in terms of popularity. Of course, the first one was the one by Johns Hopkins, but then many countries have adopted a similar infrastructure, and then beyond, provinces, states, counties, local agencies, universities have dashboards now. So we can see how popular it has become, not just by people who make decisions, but also by the entire public. I'm showing a few examples of dashboards. The first one to the top left is the Johns Hopkins one. You're familiar with that. The second one in B, that's the one by the World Health Organization. That is slightly different, works with a different platform. You have the one for France that also shows additional information, such as the variation in the R0 and positivity rate and so on. And then another one here that's for San Antonio, where the map is really not the main focus, but has a lot of additional useful information. Anyways, all of this information together is supposed to help decision makers to implement some measures if need be. So there are a lot of benefits to these dashboards. Fusing all this data into one single place, that will reduce the reporting time. What if you had data in one Excel sheet and then another place, you had other data, you had maps here and so on. You put everything into one place, and that's, of course, reduce time to decision, okay? It's very important because you can identify events that occur. So you can see that there is maybe a quick increase if you were able to look back at a few days ago. And then you can act upon it and streamline workflow, meaning maybe make more space in the hospitals, maybe try to keep people at home as opposed to use the hospitals as it was done in the very beginning. We were not supposed to go to the hospital and stay at home even if we had symptoms. These dashboards, of course, are very interactive. They are dynamic. Although that is true, but the point is the temporal component is usually not very well integrated, and that's what I will talk about afterwards, of course. We can use filters to somehow interact with the chart and possibly make changes, but also that sort of filtering is quite limited, as you probably have noticed. And it's useful to spot trends and possibly identify trends and simulate trends and events. That is more for COVID-19 simulators rather than a reporting. And finally, one thing that we need to congratulate the Johns Hopkins group is for the transparency where the data is available for download and is well disseminated. But there are some challenges. Some geographers and others have actually questioned the use of dashboard. And these are papers from this year. So these are not papers from 10 years ago. on the design and efficacy of web-based maps. So are these useful? And to that extent, if that was a question, I would say yes, it's useful because people have used it to make a decision that have maybe saved lives. One issue is that we have a lot of dashboards and some really do not look good. Because sometimes dashboards are created by individuals that have no cartographic or non-geographic knowledge. I mean, we saw some of this issue of should we use choropleth map, should we use graduated symbol, and so on and so forth. So again, there are some neat examples, but they are terrible, terrible dashboards that are really hard to make sense of. And then certain web-based maps have a potential to present misleading and politicized data analytics about the pandemics. We have all heard about the story of the person who was in charge of the dashboard there. My question is then, did we miss some opportunities? If we just map cases, death and test and other basic statistics, we may hide important spatial and spatial-temporal patterns. So just mapping in cross-section, we're missing what happened and what is the history. If we have information on the patterns, the space and time patterns, we can better understand the transmission. If a cluster does not change, for instance, then there is little transmission to other nearby geographic units. And then how do those clusters change over time? If we can track it, then that's very useful. Alex mentioned that before me. And so we think, our group think that visualizing the dynamic numbers is very important in both space and time, and that some advanced geovisualization techniques can be used to integrate that temporal component. So I'm going to focus on 3 different visualization here that try to incorporate the temporal components. So for some of you, if you're on the meeting here, if you are a cartographer, probably the first 2 techniques are not very new, but I challenge that probably a lot of cartographic classes do not teach any of these techniques, so maybe it will be new. While the third one is probably a new technique that you might be less familiar with. The data source that we use to make those maps are from the COVID-19 data repository from Johns Hopkins, and we use data from January 25th, the first day of a cluster detection in the US, to October 1st. So that's where our data stops. So 3 different approaches I'm using here: the bivariate map, spike map, and then a space-time pattern map. So the bivariate map, the idea is that it can show 2 attributes at the same time, and you have to select those colors in a good way, of course. We use 2 variables here. The first one is a relative risk, and while the second is the number of days a county in the United States, so this is applied to the US, was within a space-time cluster, and that the cluster relative risk is larger than 1 in the past 14 days. Okay, so Alex just explained extensively the type of methodology that we use, the space-time scan statistics perspective, and so we use this data as a sort of an input for these maps. Okay. So I will show you here what this map looks like here. There is actually an animation, so I'm going to shift to internet, and let me know, Michael, if you cannot see that. This here is the map that you can play with. You can zoom in, zoom out, and also query different counties. And we can see the progression here. Now, one thing that is important, right? As you see in the beginning here, we had, I'm just stopping here early March, we had cases in Kings County in Washington, starting slowly in around New York, and then also in Chicago. The legend here shows relative risk. So this is as it increases in purple, and in blue, it's the high risk cluster. So whether or not a particular county has been in a cluster for a certain amount of time. You will see that the patterns is interesting here. So now we are in March. Some counties are, remember this is 14 days. Now we can see here, we are in May, in New York. We see Southwest Georgia, and then also around Louisiana, and starting to pick up in close to Arizona. So this is beginning of the summer. In June, we started to see some also increased clusters and increased relative risk in the Midwest. At that stage, the south was pretty bad there. And yeah. So that's one approach. We can see here this bivariate map, how it changes over time. And this is for California, to the example in the bottom, and then the Northeast here. Now, the Northeast, for instance, very interesting. On mid-March, right? We had some clusters in New Rochelle and others north of New York. And then, of course, that increased, but then it actually decreased because we're looking at the last 14 days, okay, as well. So that's why there is this sort of dynamic. Yeah. The second example we use is a spike map. And so you may have actually seen this approach in the New York Times, but we feel it's actually quite a useful technique. So far what we see in dashboards are graduated symbol. The problem with graduate symbol is, as the number of cases goes up, it can really result in a bad visual clutter. And spikes may be actually more suitable. They don't expand in a 360 degree. They just expand to the top, to the north. And they are maybe more suitable to represent large enumeration units. So what we do here, we use the height of the spike as a function of the observed number of cases divided by the expected number of cases. So that's ODE. But you have extreme values of ODE. So for instance, up to 898, which is a lot. So we use a log transform to normalize the data. So there again, I will share with you the animation. So we start here in the 25th of January, case in Chicago, in Kings County, as well in here in Maricopa, which is where Phoenix is located. And we can see, so in the beginning, not much happens, right? We are now in early March, and then we can see quickly how this is spreading, and pretty much, sort of early June, majority of counties here have experienced daily cases. We see that the map doesn't seem to change a whole lot anymore. Don't forget we're using a logarithm, but you can see here how this southeast is increasing very, very quickly, and so that is an interesting pattern. And so essentially, these spikes are increasing slightly. We can of course exaggerate more if we wanted. So yes, you can see here what happened in New York in the example on the top right on March 20th, and then in early April, and how when that spike increased. Okay, our third visualization that we wanted to develop is what I call a 3D spacetime pattern. So this is essentially trying to use the third dimension in a cube, in a spacetime cube approach, to visualize these patterns. So what we did here, we look at death counts instead of cases. We estimated a 7 days rolling average, just to average a little bit better, because we know that we have elevated counts of death in the week and then low in the weekend. We use a logarithm as well because some of the counts are very high. Once we have those, so we have essentially a space-time point that contains the death. We interpolate it based on the space-time variogram, and then we use volume rendering in Voxler to map those patterns. So I'm going to first show you the map itself, which may be a little bit difficult to interpret at first. So hopefully you can see it, and afterwards I will show you a demo of this one. This is the US, of course, and what you see at the bottom, right, this sort of surface, this sort of two and a half dimensional surface, is nothing else than the population. So you have a high population in Chicago, you have high population around New York, you have very high population around Los Angeles, and so on and so forth. And the idea is that now we're going to superimpose the magnitude of the death on top of that. Now this is a space-time. So what it is that the yellow box here represent the space-time queue. Okay, you can see that there are different time span or time interval: March, June, August, and October. And we can see different interesting patterns. So for instance, let's look in Chicago here. We have not directly, but shortly after mid-March, we start to have a very sharp increase in the number of deaths. And this lasts until about June 20th, although end of May, there were not that many deaths anymore in Chicago. Similarly, for the Detroit area, many deaths occurred in the beginning, but not so much afterwards. We remember very well what happened in New York City. This is a kind of blurry because there were so many cases, not just in New York City, but all the surrounding counties as well, such as Bronx, Queens, and Kings County. Boston was a little bit less of a cluster, not as strong, but it happened also 2 weeks after New York. Now, what is interesting here is what happened in Miami. So Miami had a few deaths in the beginning of the time period. You can see here the graph, cumulative graph of death, but then it had a really sharp increase much later in the summer. Okay, and this is kind of the same pattern. This sort of second wave was very characteristic of what happened in Texas, what happened in Arizona, Los Angeles, and so on. We can rotate, and then you can see what this looks like. So I'm going to show you in Voxler, and I hope that you will be able to see it. So Michael, let me know if you cannot see this. This is our view here of the scene, the three-dimensional scene. As I mentioned to you here, we have Miami that has a very high number of cases in the beginning, and then it just keeps on increasing. We can clearly see here, you know, for instance, that Los Angeles here started very early on, but that many other cities, such as Houston, Dallas, and others, started to experience death much later. Okay, we have an interesting pattern at the border here, southern border of Texas with Mexico, a really high number of cases here. So that is interesting pattern that is worth you know, visualizing. The little one here you see is Kings County, Seattle, but very few deaths there reported. Okay. One thing we can do, of course, with this type of visualization is to filter more for some clusters. So for instance, now we really focus on these extreme clusters. For instance, in the Chicago area here, New York, and others, and we can see the one that are the most significant. Okay, so I just want to wrap up because it's time. Dashboards are a great platform to fuse data from different sources to improve decision-making and communication to the general public. But I really feel that they miss the opportunity to better render dynamics of infectious disease. So it's really hard for us to really understand those dynamics. We propose here some straightforward visualization techniques that better incorporate the temporal dimension. And I really think, you know, as a cartographer here, that map makers have to think beyond the traditional graduate symbology that you see in all of these dashboards, because it leads to a lot of cluttering and even corrupted map, especially when we have to reflect the temporal component of the disease. So we have, I think, to think a little bit beyond the box. And that was my recommendation. And I'll take you know, some questions afterwards. You have my email address here if you have some questions. Thank you, Michael.
Thank you, Eric, very much for that nice presentation. At this time, I'll ask all the presenters to turn on their video and audio. And we have about 5 or 6 minutes for an open Q&A. I guess I'll start with Eric. I have a question. Do you know if there's a way to automate these visuals in Voxler? Because if you were to do this every day, are you doing this manually, or is there some sort of thing you could do on the back end to automate this?
Yeah, so in this case, this has been done manually, but there are some ways, especially I think using D3 and Java to make it interactive. So the volume rendering and all of these techniques are, you know, somewhat close to an art of really selecting and calibrating those. But I think it has been possible to even put that on the web. We have seen some examples of that. That would require very strong graduate students with programming skills.
So Voxler is not the only software that can do these sorts of
No,
space-time
you can do that
visualization.
over the web, yeah.
Yeah. And why don't you think we see more of these space-time visualizations in infectious disease research in general?
Excuse me, can you repeat?
Why don't you think we see more of these space-time visualizations in infectious disease research in general?
Well, I think partly because the GIS software, we're not really good at handling time. I mean, we can start to see now that, for instance, Esri has a temporal, space-time cube, space-time analytics package, but this is very recent, and it will take a while for people to get used to it and how to use it in a way that can communicate those patterns better. So it will take a while. I mean, time has always been a weakness of GIS. So.
Yes, thank you. And another one for Eric before we switch gears. For dashboards with a more general audience, do you believe that they would have the sophistication to understand these more advanced visualization techniques?
Thank you, Matthew, for this question. Well, I mean, if you think about a spike map, that's not really hard to understand, right? I mean, this is pretty straightforward. I mean, it's not so straightforward to do, but it's straightforward to understand. I think this bivariate map, it's probably not maybe for the very, very general public. But I think if you think a little bit about it, it actually can be, it's not too hard to understand. Once you start going on to this 3D, I think the audience is more sort of the scientist. But once you start to reveal some interesting patterns of, the disease is a cycle, comes back and leave and comes back, that's really relevant, and it would be really hard to make even through an animation, for instance. So I think, I really would hope that a lot of people who create these dashboards and others, we see so many maps that are being made now, have also a good training in cartography. And I think that is sometimes missing. And that's why we see some dashboards that are also terrible.
And this one's for Ensheng. Do you receive estimates of uncertainty from any data sources, or do you make your own approximation on which sources are most or least reliable? For example, are there certain areas from where you receive more alerts about potential errors, and how do you manage that?
Yeah, we are constantly compare different data sources, like the one we compare with WHO, we compare with New York Times COVID tracking project. And sometimes we see there's a spikes no matter which data sets have. We will email to the local government or the Department of Health and asking what's the real data, can they release to us? Because of the fame of the coronavirus dashboard, when we email the health department, they will reply to us because of you're from Johns Hopkins, that's the best part. But for other parts we cannot confirm. We will just keep a note in the dashboard, no matter in the issues. We have the issues forum, and also in the modification or anomaly list. We have a list over in the GitHub, so everyone can go there and check if the data is reliable or not, or did we make any change in the GitHub.
Okay. Thank you. Yeah, and if you have any more questions, please feel free to type them in the Q&A. Our panelists were gracious enough to answer many of the questions before this Q&A session. So go ahead and look at the answered column to see that. I have a question for Alex. Have you done any sensitivity analysis with the parameters for the spatial and temporal scan, and how do you think this would affect the clusters?
Yeah, no, I haven't had the time, but yeah, I mean, this, as with any, like clustering algorithm, the parameterization is key. Okay. So yeah, we absolutely should have different parameters, and there is some work out there, especially for StatScan, that guides you in finding these parameters, right?
Yeah.
And yeah, so that's absolutely something we need to do, and hope to find the time further down the road to perform this kind of research.
Yeah, because you don't see many papers that do sensitivity analysis, and you have these very large clusters like, in the Midwest, for example, but displaying the relative risk of the counties that belong to a cluster is a way to circumvent that issue. So yeah, it's definitely something to do in the near future. I have one more question before we wrap up for Ensheng. When was the Johns Hopkins dashboard launched?
It was launched on January 21st, but we officially announced it on the second day, January 22nd.
Okay, thank you. Okay, with that being said, thank you everyone for joining. Just a couple of quick notes. I'll share my screen. Yeah, so thank you all for coming. As a reminder, this session was recorded, so it'll be available after our final session today. If I go back to the first screen, we have a session at 3 p.m. on mapping industrial food animal production. So thank you everyone for attending this session on COVID-19. I'll drop a few links if you want to check out information about that session and our co-sponsors, the Center for a Livable Future and the Spatial Science for Public Health Center. So thank you very much, everyone, and have a good day.
Thank you,